Let's talk about financing. And we've talked about this a number of years, a number of times now. Financing our healthcare system. Universal health coverage is one of those that have been touted as part of the Big Four agenda. The progress of the universal health coverage is still there. We know, they're working on how do we structure NHIF so that everybody then has access to some form of insurance. How do we increase the number of health facilities in the country so that everybody has access to a nearby health facility? How do we supply all these facilities? How do we equip them? How do we hire personnel into these facilities? All those, generally from a global perspective, are things about universal health coverage. But then, how do we finance it? Let's talk about HIV/AIDS, a field in which you've worked for a number of years, CT.
Yes.
HIV/AIDS in the country, according to some of the latest statistics from the National AIDS Control Council, we have over 65,000 deaths annually as a result of HIV, tuberculosis, and malaria. The number of people on antiretroviral treatment in the country is about 1.2 million, 1.5 million people who are receiving medication for HIV, malaria, and the rest. Where does this money come from? And we're talking about money to buy the drugs, money to build the infrastructure and sustain the infrastructure, money for staffing and to pay the staff. 70% of this money basically is coming from overseas development assistance. This is donor funded, and we've talked about this many times. Our healthcare system has largely been supported by donors. Our government doing about 30%, especially in the area of HIV, about only 30%. Now, with the changing times, just like you talked about the other day, the Global Fund, the PEPFAR, and the others saying, now, it was a pandemic a couple of years ago. It does not remain the same. Because we've been financing, we've been expecting that things should be improving, and you'll now also build your own capacity to sustain. Are we able to sustain financing the healthcare needs, especially in HIV?
The answer to that question is another question. Are we willing to finance it, or are we perhaps more complicit in trying to maintain the position of constantly looking for handouts when it comes to financing this very key sector in our economy?
If it ain't broke, why fix it?
Actually, it was broke. The whole process of funding was to try and fix it and to make sure that it stayed fixed. And all the efforts that were made were geared towards that. Everything you've mentioned, from ensuring that you have the capacity, from ensuring that you actually stabilize the whole care system so that it doesn't get out of control. All that was done. But also with the understanding that with every passing quarter, with every passing season, with every passing period of funding, these are 5-year funding periods, there would be an understanding and audit of what is happening and a refocusing on areas that require more help as opposed to others.
Yeah.
And the focus on how to ensure that you maintain perhaps a community approach to it so that at the end of the day, this very same thing that you're saying is able to be done. And funding was appropriated in such a manner. And even the process of understanding that the funding would reduce and the focus would be in other areas, all these discussions took place over time. I'm repeating the took place because with every year you were told, this is what we're going to do. Yeah. With every year, because it's not as though you're given the money for 5 years at a go. It's on a year-to-year basis. Careful monitoring of what is being done and how we need to focus on it. So after all these years, if someone comes and tells you that we're still not able to cope, well, we have institutions where we take such people so that their mental capacity can actually be determined.
I was wondering which institutions this was.
Yes, because that money, given that the funding, any funding you talk about for HIV didn't just take care of ARVs, it also took care of the opportunistic diseases that came with it.
Yeah.
And you know what? It was free. It catered for personnel whom you'd employ. It catered for all these. It was free. So surely, if all these needs were taken care of and it was free all these years.
If infrastructure was built over the years with this free money.
Yes.
We don't need to.
So should you not have been in a
building the same
position
infrastructure
to actually be able to take care
to
of
take up some of these costs?
precisely?
We are now in that phase because the donors have indicated, things are changing. We also have our own needs, and we also have other needs that require the same kind of money that's coming from our taxpayers. So you need to start thinking about how to sort yourselves out. So in this transition phase, where we are looking at how to sustain domestic financing for HIV and AIDS as part of financing our universal health access, let's bring in somebody from the National AIDS Control Council. Josphine Kaberia is the head of costing and expenditure analysis at the National AIDS Control Council. She's now on the line. Good morning, Josphine.
Good morning, and how are you?
Very well, thank you. Thank you very much for joining us.
Thank you very much too for hosting me.
Now, we are at that point where we're in the phase of transition. We need to think how to move our budgetary allocation in this particular field of HIV from only about 30% to 100% if possible. This is not a mean task. This is something that requires a lot of effort, a lot of work to be done into it. But first of all, what are the needs? What are the things that the government has been trying to do, especially now from your coordinating point of the National AIDS Control Council, in terms of changing our thinking of how we can finance this budget? Where would the money be coming from?
Well, and thank you to you once again. Kenya has for a number of years been a beneficiary of overseas development assistance to finance very strategic programs, including HIV. Times are changing, epidemic is evolving, and a number of things have to be changed. Kenya has been focusing on what is it that then we need to do differently so that we are able to safeguard the gains that we've accrued over time using other people's money. As a government, we've seen this, and we are focusing on a number of things because HIV and other strategic programs are also a facilitator of universal health coverage. So having said that, the government is adopting an incrementalism towards budgetary allocation. We know over time health budget has almost doubled, but having said that, HIV is not the only program that Ministry of Health focuses on. So other things that the government is keen on is improving on efficiency. That also now gives us more health for $1 that we spend. The government is also keen on other health enablers, such as good infrastructure, electricity, and generally improving health systems so that if I'm a patient living with HIV, or rather a person living with HIV, I'm able to get my medication in the nearest dispensary in my county or in the grassroots, other than now incurring an additional cost to access these medication elsewhere. So generally, yes, HIV is heavily donor funded, but government is not sitting back to look at the 1.2 million who around ART suffer. There are things we are doing, but we also need to appreciate that resources are scarce, and we know our government. We have a number of needs, looking even at the current budget that is being read today. So the government has put in place a number of things. But what we are trying to say as National AIDS Control Council, then there are these things that are very close to our hearts that we are saying the government should be keen to provide. And one of these things, even as we transition, we might not be able to transition the entire system that addresses issues of HIV. However, we are trying to look at what is it that we can do almost immediately. And one of the things that we can do almost immediately is having some money set aside and put in the budget to address the very immediate issues of commodities. The commodities that we are looking at are the commodities that we are saying, this is life-saving, we can't do without. And this is what we are saying, even as we plan, even as we try to put our country together to be able to take our responsibility, then we need to start immediately setting aside the money for commodities so that this can be a starting point, even as we start reasoning, how do we then support the health care workers who have been initially funded by donors.
Okay.
Thank you.
All right. So this transitory period, what are we looking at? And I hate to do this, but I'm going to have to liken it to another transitory period that was given in this country. Then, when it came to things like blood donor, blood, excuse me, the blood in this country. Now here we are. Are we looking at 5 years? Are we looking at 1 year? Are we in the period whereby donor funding is, they've given a timeline as to when it's all going to end? If we can hear that, then I will ask my next question.
All right, let me say that we are seeing donors are leaving. It is a yes and no question. Resources might be declining, but we are not saying that donors are waking up and leaving tomorrow. They will eventually leave. And because these monies that donors give us mostly are like for HIV program, they are off budget. So donors will come today and tell us, we are reducing your money from 11 billion to 7 billion. So we are saying the government needs to focus and put mechanisms in place to continue taking what the donors are leaving behind. Donors might not leave, but they might be having different focus or different priorities. They might stop giving us commodities and support something different, putting in mind that we have also emerging epidemics like COVID-19.
Yes.
So the government needs to start absorbing what the donors are likely to leave behind when they're focusing at other priority interventions for different reasons, and also not prioritizing Kenya as a country that is poor, because Kenya is already a lower middle income country, which is supposed to co-finance or even rather raise quite a good percentage of funding for its own healthcare system, at least to 50% plus.
Okay. Is it possible, from where you sit, what you've seen over the last period, is it possible for a program like this to be run solely by Kenya without donor intervention?
Let me say that managing our current response, or rather putting resources into this program, especially HIV, it's not easy for Kenya, but we are saying we have a responsibility and a constitutional obligation to take care of our responsibility of taking care of the 1.5 million people living with HIV is solely the responsibility of Kenyan government. The donors have supported us. We know they are living and it's going to be painful. If I can give an example, using first-line medication on average, we require 13,000 to put someone on treatment for 1 year. If you take that figure and subject that to 1.5 million people, it's quite some good amount. We know our situation. It's not going to be easy, but we can do things differently, including trying to bridge gaps, going systematically. We are not saying that we are waking up one day and telling the government, please give us 125 billion to take care of PLHIVs. But we are saying because we are aware donors are living and they started to tell us we are going. We've been with you for this number of years. We've helped you build systems. Please now start focusing and owning this response. So the government at national level and county government needs to own the response. Having said that and saying that it is quite some investment, we need to focus in the right way so that we are also putting investments in ways that are preventive and promotive, so that we don't continue putting people on treatment, because treatment is not easy. It's a bit costly, but preventing is a bit easy to do. So our request as National Health Control would be for the county government and the national government to put resources to interventions that are preventive in nature. To prevent one HIV case is easier than putting someone on medication or rather on treatment.
Okay. Did the mandate or does the mandate of the council include any kind of commercial activities for fundraising outside of what donors give?
Yes, of course. part of our mandate is to do resource mobilization, either from donors or locally, and that is one area we are focusing on. In the current Kenya is strategic plan, which seeks to have 48 billion as a cost of implementing different interventions over the next 5 years. The National AIDS Control Council has cascaded these in count levels, and we've come up with the count AIDS implementation plans that are very specific to counties. And what we are trying to achieve by doing this is to have counties identify their own problems that are very specific to counties, so that then at county level we are able to say, this is what we require to conduct our own interventions for HIV response. These are the resources that are available, and this is how we need to domestic mobilize for resources, including from private sector. So National AIDS Control Council has a responsibility to do domestic resource mobilization.
There's a program that was started by UNAIDS. It began with, well, it was 1990, and then in 2014 it was 95. Close to 100, not quite there. Talk about 95 of people living with, well diagnosed as living with HIV, 95% on ARVs, 95 virally suppressed. Now, if these goals were met, the understanding, as far as I know, was so that the cost of actually getting to treat people and to manage the whole aspect of HIV would be something that would be easy to manage. As a country, where are we with this? The 2014 declaration by UNAIDS on the 95. Where are we?
So on the 1990, where we are saying we need to identify 90% of the people living with the HIV and putting 90% of the 90% identified on ARVs and ensuring that the 90% of the 90 is virally suppressed. So Kenya has made progress in having viral suppression as a way of reducing infections, and we've really achieved towards our 90% rule. And this is why we are saying that when donor resources are reducing, then we need not claw back the benefit, or rather the gains that we've already accrued.
Allow me to stop you at that particular moment. Just let me stop you briefly and ask, how far are we from the 95? Not even the 90. How far are we? Are we at 15? Are we at 40? Are we at 80? Are we at 89? Where are we?
Kenya has managed on a number of these three aspects to achieve a 72%, which is a good progress. And that's why we are trying to say we need now, because we are talking about ending HIV by 2030, we need to really put a lot of our resources on preventive interventions, even as we focus on incurring the cost that we have to incur to put the people who are supposed to be put on treatment.
What you're saying makes a lot of sense, but if you're talking about viral suppression, and if you're talking about adherence, and you cannot do all this without talking or referring to community involvement. Now, it isn't NACC's job, but I have to ask the question: what efforts has not NACC NACC done with the Ministry of Health to ensure that the community support systems that enable all these three aspects are adhered to? What is it that has been done? Because do we see a greater focus on funding on community efforts, or are we still seeing a focus on clinical efforts with regards to ensuring that we have HIV under control?
We are really focused on community health workers. And if you look at the structure of National AIDS Control Council, it's a devolved structure that goes all the way down to sub-counties. So we have a lot of community engagement to try and help us to address the response right from the community level.
I like the fact that you're saying that there's effort being made to do this, but you can't achieve this without the collaboration of the Ministry of Health. The Ministry of Health structure when it comes to the deployment of human resource within the health facilities, what is the focus of ensuring that the ministry, actually, I know health is a devolved function, but the Ministry of Health has a big say in these matters. How much effort do we see the ministry placing on ensuring that we have human resource that can actually carry out these functions from a community level?
I would say that National AIDS Control Council, NACC, as well as the Ministry of Health, focuses on HIV issues, bearing in mind that HIV response is a multi-sectoral issue. The Ministry of Health is supportive. We have community health workers that are paid to specifically identify, link people with care, and I would say that our community engagement are strong, and this is also something that we are focusing on improving under the new Kenya AIDS strategic framework and the county implementation plan.
Josphine, as you said, this is a long journey. It's a transition phase. There's a lot of work that the National AIDS Control Council has done so far in terms of planning, in terms of re-strategizing and reallocation of some resources. So it's a conversation that we need to have over and over again as we see the progress. So this year, maybe the funding in the healthcare moving from 70% donor to reducing to 60% donor, and government taking up more and more. So we will have to invite you again so that we can keep track of this progress.
That would be good.
Asante sana for joining us today. Josphine Kaberia is the head costing and expenditure analysis at the National AIDS Control Council. We've been talking about financing, sustainable domestic financing for HIV programs in the country. We know that so far the HIV sector has been heavily funded by donors, overseas development assistance, and about 30% of the needs or financing needs being funded domestically. But now this needs to change, and that's what we're discussing. Thank you very much, Josphine, for speaking to us today, and have a lovely day.
You too. Bye-bye.
Bye.
This is the Situation Room, the only way to start your day. Spice up your life.